Hello, everyone. Bonjour. We'll start in a minute or so while everyone gets to their screens. All right, it looks like there's been a little bit of a plateau with participants coming in. So Pascal, I think we might go ahead with the introductions and then carry on with the panel.
Sure, let's do this, Jenna.
Sounds good. So thank you all attendees for being here today to listen to our panel discussion. And thank you as well to all of our panelists. My name is Jenna Roddick. I'm with the APTA Hub, and I will give a brief introduction to that shortly. And I'm here with Pascal Beauchamp from Numana. So today's panel discussion will be initiated by a brief introduction to the co-hosts, myself and Pascal, and our organizations, and then we will move along to a panel presentation and moderated Q&A discussion, and then we will wrap up the day. We would love to acknowledge our panelists and the organizations that they are representing today. It would not be possible without their participation, and we look forward to their insights. So before we move forward further with our introductions, I just want to say that our simultaneous transcription is not working today. The majority of this will be held in English, and transcription from French to English or English to French is available if possible. So just reach out in the chat or after the fact. We will make sure our contact information is available.
So this is mine. So thank you, Jenna, for the introduction, and welcome everyone to this very exciting conversation today. And as Jenna mentioned, although we have this little mishap with translation, please do not hesitate to communicate with us for any further information. Rather it is in French and English. It will be an honor for us to share the knowledge of today. So for Numana's side, so here we are. So today we are an actor in the ecosystem here in Quebec. So as you see, we've positioned ourselves as the healthy aging and well-being ecosystem since 2019. We started work earlier in 2016. And today we are here. So as you see, our motto here is Numana to catalyze this ecosystem for health, well-being, and aging in Quebec. You can see where we engage. We have a main focus on the autonomy of aging population in a chosen environment. So we are looking into new emerging models here in Quebec, so living labs and action and research projects and laboratories that are moving forward. And this is a radar that we've been having a scope since the past 8 years. As you can see as well, we look at well-being in the workplace and in preventive health. We do believe that the workplace is a beautiful environment to be able to build strong culture around well-being for general population. We are also moving forward with Quebec's main caregivers association into their digital transformation. And as you can see, some of our working groups at Numana. So we have a think tank, which is our main committee who gives us the scope and radar on the landscape of what is changing in Quebec when it comes to aging challenges and new emerging models. So we also are involved on 2 living lab projects here in Quebec on the steering committees. As I mentioned, well-being in the workplace. So we're putting together a think tank with Groupe Entreprises en Santé, which is Quebec's main hub for health in organizations. And we assure government relations with health officials in Quebec. And we are partnered with the CH Alliance and Laurea University of Applied Sciences in Finland for emerging models such as living labs. And in Finland, they have this amazing network of 15 living labs on well-being and aging in place, which I really encourage you to have a look. Finland has a very strong model. So in a nutshell, that's for Numana. So welcome again. Thank you, Jenna.
Merci beaucoup, Pascal. So thank you again for being here today. Similarly, I'd like to introduce APTA. So APTA is one of AGE-WELL's 4 national innovation hubs, and we stand for Advancing Policies and Practice in Technology and Aging. We were established in 2017 and jointly funded through AGE-WELL NCE and the Nouveau-Brunswick Health Research Foundation, with a vision to drive policy innovation that improves the lives of older Canadians. We do this through 3 core areas of operation: knowledge translation, exchange, and fostering innovation. We work with governments to identify policy priorities that could benefit from research learnings, and we then connect researchers and organizations working in those areas to bring forward knowledge, insights, and translating that to an appropriate context. We have platforms for knowledge exchange and that provide further opportunity to share and learn and connect through government stakeholder meetings, workshops, communities of practice. And we also offer researchers platforms to share their work through the generation of evidence products, webinars, and more. And lastly, we engage with research trainees through our education programs to instill knowledge translation and policy making capacity earlier in one's academic journey. Over the last 5 years, we've covered these topic areas and some more with many different collaborations and mechanisms for these projects. We've done literature reviews, jurisdictional scans, workshops, co-developed policy briefs, and informed recommendations, all in an effort to bring forward the information to our government stakeholders. We have a policy prioritization process, which analyzes the topics that come out. We collaborate with our stakeholders to compile a list of policy priorities, and then we look at the outer context, what's going on across the country in terms of political priorities for the aging population, and try to align ourselves best to best serve and improve aging in place. Our current priorities, we have 5 current policy priorities that we are establishing ongoing research partnerships with subject matter experts and organizations that are within these fields. Lastly, one particular approach that we take, specifically both of these topics have addressed aging in place, but we bring together stakeholders from multiple sectors through multiple perspectives and lived experiences to address a complex challenge through our innovation lab process, with the ultimate goal of developing and co-developing solutions to those challenges. So we've addressed home care and home support services to enable aging in place or the place of their choosing, and how might we enhance adoption and scale of health technologies, specifically in the New Brunswick context. Both of these processes took about a year to 2 years from planning to execution. And lastly, through all of these activities, and just to highlight our framework, We aim to achieve better evidence-informed decisions and better capacity among the research community to highlight their research impact and applicability to the policy context. And with that, we foster environments of collaboration, continuous improvement, and learning. So without further ado, and with further learning, we're delighted to hand it off to our panelists today, who are here to represent their work and their organizations as it relates to the importance of aging in place. So I will stop sharing my screen.
Thank you very much, Jenna. And as you can see, for Numana, AGE-WELL and a PPTA is a very inspiring group and network that we are inspiring our model to be able to adapt and be able to bring down the barriers here in Canada and break the silos, as we say, in innovation ecosystems. So again, it's a real honor to be able to share this day with AGE-WELL APPTA. Thanks a lot again, Jenna, for the organization along the way. So we would invite Jane to come forward. Jane.
Great, thanks. And we've had the opportunity of working together, Jenna and I, and so I can definitely attest to the great work that APTA is doing and continuing to do in partnership with us here at MEC2 around HSPP. So I'll talk a little bit about what HSPP is, some of our processes, some of our learnings, and set us up for a panel discussion around the same. So what is HSPP?
Is it not advancing?
Not yet. It will. Yeah. So what is HSPP? Is the $75 million investment from the Public Health Agency of Canada with the government of New-Brunswick. This was initiated in 2018 with the goal, and that's really highlighted at the top here, of supporting a range of applied research initiatives to examine how government can better support seniors in their home, communities, and care facilities. So the initiative itself is jointly led by the Departments of Social Development and the Department of Health through the Seniors and Healthy Aging Secretariat. And again, these are applied research projects designed to explore pilot initiative interventions to foster healthy aging in New Brunswick and share what can be learned across Canada. And there's a variety of different projects. Some are led by communities, some are led by government, and some in partnership. And all projects are supported by us here at MEC2, which is the Monitoring, Evaluation, and Knowledge Transfer Unit to ensure strong project and evaluation plans. And I'll talk a little bit more about who we are here at MEC2. So again, MEC2 is not the fanciest name in the world, but it definitely does describe exactly what we do: monitoring, evaluation, knowledge transfer. And really our why is that we maximize the investment by providing start to end support for HSPP on design, evaluation design, the monitoring component, and knowledge transfer. So essentially we work with all projects to help ensure that the applied research component or the evaluation plan has the rigor that will provide key project learnings. Because again, what HSPP is designed to do is try something new and to learn what the impact has been, and then to share those learnings across Canada, in the province and across Canada, and internationally if applicable. And we also, not only do we work with projects to ensure that strength of evaluation and research plan, we also monitor the project progress and report as required to GNB. I think that's an important component because as all projects have a different life cycle, they all have different end dates, that it's important that if there's any findings, any learnings that can be shared, that we don't wait to the very end so that our funders are able to learn as we go. We also are here as a resource to help troubleshoot any initiatives or any issues that may arise. A key one that I'll speak to a little bit later as well is that we provide knowledge transfer, leadership, and support to projects in order to support sustainability. As you can appreciate, with a $75 million investment, we need to evaluate what the impact's been, and we here at MEC2 are here to help support that wrap up and evaluation. So what are some of the intended focus areas of HSPP? So HSPP is divided into 5 focus areas. So these are 5 areas that we want to see an impact in as a result of the different initiatives. There are a number of projects within each of these buckets or these focus areas. They go from social and built environments, increasing independence, quality of life, and promoting healthy lifestyles, using community approaches to reduce health inequalities, developing innovative care pathways, and technologies to foster healthy aging. So while these are unique and independent focus areas that are designed to have various impacts that are in the outer circle that you'll see there, there's also common linkages between the two. Many projects will touch upon a number of these different focus areas. And again, that you see on the outer circle what some of the intended impacts are, and these are collective impacts. So to use as an example, improve social outcomes, that there may be 10 projects that have an intended impact of improving social outcomes. They may all be measured differently, but collectively we will see what the implications have been on improved social outcomes. And that's just one example. So what is the HSPP life cycle? And this talks a little bit more to the process and how the strategy or the model that we have here at MEC to help support these projects and ensure that we get that value and understanding how we can improve the lives of seniors. So at the very beginning, there's the project approval and intake process. We here at MEC2 do not have a role in terms of what projects are approved. That is through the funders and at GNB. And so once we receive a project that has been approved, we then go through what's called an intake process, where we work with each of the individual projects to, again, make sure that the applied research component of their project has the strength and rigor that will ensure that there's learnings as a result, and that there's also a project management plan, Gantt chart, so that we will be able to, the projects will be setting themselves up for success to be able to meet the milestones and deadlines that they've established for themselves, and that there is a KT plan from the very beginning. So once that project has been initiated, we again immediately start with the KT activities, and one area that we are really focusing on now is the implementation, sustainability, and scale-up plans. So in terms of, you'll see that the different touch base here in terms of ongoing reports, project and reports, and evaluation. So I almost like to work backwards on this third layer, is that the evaluation plan for HSPP as a whole includes both a process and an impact evaluation. From that, what we know that much of the information, or a large percentage of the information, will be gathered from the project and reports of each of the HSPP projects themselves. So we want to set the projects up for success to be able to tell us what the information is that we need for that evaluation. And so that is that we have the project and reports defined. Then you work backwards to the ongoing reporting, which is on a quarterly basis. And we ensure that the information that we will require for the project and reports are being gathered by the individual projects, so they don't find themselves at the end of the project and say, oh, I should have collected that information. And so they know that at the very beginning, what are some of those outcomes, learnings, outputs that we want to learn along the way. In addition, the ongoing reporting, quarterly reporting, allows the projects to tell their story so that we can help inform GMB as HSPP is evolving. So there may be some informal or some initial learnings regarding informal caregivers, as an example. And so those are really important. We don't want to wait till the very end of the project to be able to share that information with GMB. So it's important that those types of informations come on a quarterly basis and while projects are learning. But we also know that project management, research, evaluation does not happen in a straight line. And I think COVID has taught us that we need to pivot. So we work also with projects to help make those amendments so that we can still have that same rigor, but in a way in which meets current realities. So as realities change, we need to pivot with them. And again, the reporting to GMB and the Public Health Agency of Canada is throughout the life of the HSPP. So where are we right now? And what are we looking at? So we are currently working with 65 different projects. As I said, there's all of the focus areas, the 5 focus areas that I showed before. We have a number of projects within each of those buckets. But we know they're at different stages. And right now we have 5 projects that are complete. And we've categorized the stage based on whether they're just being initiated. So maybe they're doing their REB, they're hiring, they're getting ready to implement. Then there's the implementation phase and the evaluation phase. Again, it's not as linear, but it's just a good representation of where they are, what we can expect to learn as projects are evolving. So we have 16 projects in initiation phase, plus 10 new coming. Implementation, there's 21 projects that are they're in the implementation phase and 13 that are technically in the evaluation phase. So some of our measures, and these are part of our indicators for PHAC, and part of them, it's not the fulsome picture, but is participants and individuals reached. We had a target of 5,000. We've exceeded that. And this is as of Q1 for 22-23. So we're at 6,569 at present. Projects reporting increased knowledge or skills amongst participants. So in other words, have the participants that are participating in the project have learned much. 80% was our target. We're at 90.5%, which I think is really good, because when you look at the number that are in initiation phase, you can't really learn a whole lot at that stage. So projects that identified facilitators or barriers to program delivery, we want 100%. Again, 98% have identified facilitators or barriers to program delivery. One of the really interesting parts of having that bird's eye view of 65 different projects is that you get to see every quarter, you almost do a research project and what the learnings have been, what are the collective learnings. And so these are some of the common themes and observations that our team have been able to pull from the Healthy Seniors Pilot Project's quarterly reporting. And this probably will not come as a surprise to anyone on the call or in the webinar, is that transportation is a key issue. And 50% of projects identify transportation as a barrier. And that impact is compounded for low-income rural seniors. And that's significant because there are many projects that transportation wouldn't play a role in at all. And so what are some of the common mitigation approaches? Is that we've seen projects as a result of that barrier identify multiple service locations, ensure that their locations are on a bus route, providing bus passes, volunteer transportation is a key solution, mobile services, so going to the senior instead of the senior coming to them, virtual programming, which in some ways was an initial barrier because of COVID, but they've seen that projects have identified that that's a positive aspect now because they're able to, this barrier has been able to be mitigated. And informal caregivers in terms of being able to provide transportation. But again, if I go to the next bucket in terms of what some common themes of and observations is around caregivers, and that 28% of projects identified the need to support informal caregivers. So that they were a key enabler or hindrance to be able to get participation. And some of the key issues include caregiver schedules, stress/burnout, which I think that everyone can identify has been increased as a result of COVID. Some of the mitigation approaches include scheduling work around caregiver schedules, navigation support, covering caregiver costs during project participation. They have an opportunity cost if they're participating with their senior, and providing respite to, again, help prevent burnout. Technology, 38% of projects identify technology as a key learning for the project. Key issues include accessibility. Do they have access to the internet? Do they have access to the technology? Fear of technology and comfort level. And again, what we see in transportation, this barrier is compounded for low-income rural seniors. And again, the primary mitigation approaches include additional supports and training. How do you make it comfortable for seniors to be able to appropriately use the technology? And quickly, I'm conscious of time, go through some of the other common themes that we've seen is awareness in terms of how do you get the message out, and having a good community of practice amongst our Healthy Seniors pilot projects. And the nice thing is too, is New Brunswick's a fairly small community. So many of the researchers know each other, so they're helping support one another in terms of common recruitment strategies, and partnerships between projects. But projects have also identified the importance of community support and local promotion and media promotion. Costs, again, the importance of providing services at zero cost. Gender, more difficult to secure males as participants in studies. And a key one is being staff burnout. And I think that that's just even heightened as a result of COVID. So lastly, I'll talk a little bit about knowledge translation. So we have a target of 65% of all projects to be sustained or ready for scale up post HSPP. And we also want to support evidence-informed decision-making. So that's our why. Why do you do it? And so, and then you'll see the KT goals there, is that what we want to do is we want to generate awareness, share knowledge, inform policy, inform practice change. And for each of these, we have different strategies because we know there's different targets. And we want to inform research, gain KT buy-in, to build capacity, because this is a new skill set for many researchers that are working so diligently on these projects, that those skill sets of how do you actually translate that information into something that can be heard by GMB or by the practitioner that you want to help change the practice, and building relationships. So our strategies that we've used to date are showcases, podcasts, KT plans. So all HSPP projects have to have a KT plan that we have a wonderful KT officer here that works with each of the projects and is supported also by Jenna and team. And again, that KT support, community of practice. And we're finding that this is a really valuable method of, again, sharing what some of the struggles may be of individual projects, what are some of the common practices. So having that community of practice is really valuable to help projects progress as they need to. And a MEC2 newsletter quarterly. And we've recently engaged with the Center for Implementation to do learnings with respect to implementation science. Again, to have that education around how is it that you can set yourself up for success to be sustained. And it's not just all about money, but there's also many other parts of implementation science that need to be considered by these projects. So that's it for me. Thank you very much. And I look forward to hearing your questions.
Thank you very much, Jane. Very instructive and highlighted the knowledge, setting the table quite in quite perspective matter. And one thing I need to share before letting Joanne walk us through her presentation is transportation. That's quite funny because we've just as well in the ecosystem identified that in Quebec as well, transportation is a huge one. And we are walking into conversations with smart city officials around mobility and getting this conversation going this fall. So that's interesting.
It'd be great to learn from one another.
Oh yes, we will. This is what this table is about, and setting the table for the future. Indeed, we will continue to share knowledge. So thanks again, Jane, for opening up this session. And now, Joanne Castonguay, our Commissioner of Wellbeing and Health in Quebec. Joanne, à toi la parole. Merci.
Thank you very much, Pascal. So I am trying to show my presentation. Can you see it?
Oui, yeah.
Is it in presentation mode?
It is.
Okay, thank you. Oops, I'm not at first page, so sorry for what I'm having you go through.
That's okay.
I think,
Sorry.
I think I can see your notes. I'm not sure if maybe it's lagging on my end.
Really? Okay, I'll try something else. Okay, I'll stop this. Okay, and then I'll share.
If you're using two screens,
yeah, but it's not really working. That's the issue. So okay, so now can you? Is it better now?
the sharing is off right now.
Yeah.
It's off.
Yeah, we can't
Okay.
see your screen right now.
Is it on now?
Oh, it's coming. Yes.
Yeah.
There we go.
Okay, do you
got
see my notes?
Mhm.
Okay. So thank you very much, Pascal, and thank you, everyone. And thank you, Jane. When you said we could share, I have so many questions just from your presentation. I think that, you know, Pascal, we can animate this if you want.
Yep.
And ask the questions.
Oh, yes.
Anyway, so I was asked to present what my organization was all about, and how we what are our interventions, our activities for the aging population. So first I will start with telling you a little bit of how we set up the organization, because it's an organization that was dismantled. It was first put together in the beginning, well, around 2005, and then it was dismantled by the previous government and put back into action. I don't have the appropriate words. Please excuse my English, but anyway, I think you will get the ideas. So essentially, we were put back in activities just before the COVID crisis, the pandemic. So, so what we did is, the first thing we did is, when I started this job, is I was thinking, you know, what is the issue that is the most important for me, and where would I like to be making a difference? So I will basically present to you first how we got about that. I'm trying. Okay, so the context element. So what was the context when we decided to establish what was going to be our main activities, and what are the basic, the most important issues in the system itself? Then how did this basically help us define what our mission, how we were going to realize our mission? And I will tell you a little bit about the mandates that we did on elderlies. There were two mandates that we received from the National Assembly, so that is from the government, to tackle issues on the crisis, and the second one is to tackle issues on the home care. So first of all, the context. So one of the main issues that is very important that we start understanding, or at least that we are aware of in Quebec, is that the health expenses, public health expenses, have been increasing much quicker than the GDP over the last 20 years, if you'd say. So the impact of this is that it has diminished our capacity to invest in other mission of the government, on other public services. So education is one of them, environment is one of them, and as you know, many other programs. So if we just look at this, in 1989, healthcare was grabbing 35% of government expenses, occupying 35% of government expenses after debt services, and now it occupies 51% of government expenses after debt services. So it's humongous. So it's really preventing our capacity to invest elsewhere. So one of the things that is important is one of the main, I'm sorry, my English is so bad today. So basically one of the important idea that we have behind our mind is that even though we increase our healthcare expenses, there's a limit to the health adjusted life expectancy that we can get. So that means that we can have much higher results, much better results without increasing our expenses some more, because we are probably here. So we can improve our performance, our health system performance, without increasing our expenses. Another issue that is very important is the independence ratio. If we look at 2000, in the year 2000, there were 5 people of the age in the group, the age group that is of working age, that is between 20 and 64, for each 65 years old person. So that is 5 people working of age to support one person in the 65-year-old group and older. Today, it's approximately 3. It's between 3 and 2. In 2030, it's going to be 2. So basically, the amount of people working and working towards producing GDP is decreasing. So if we keep on increasing our expenses more rapidly than the GDP is increasing, the problem of grabbing a greater proportion and diminishing the government services and other services is going to be diminished even some more. And another issue is that if we look at this is oh my God, working. Pascal, can you help me there?
Yeah. Where the evolution of vacancy in
employment.
And employment.
Recruitment.
Yeah.
These are the recruiting place available. We're recruiting people, and there's more than 35,000 post places that are available, and we cannot find the human resources in order to occupy these jobs. Job opening, oh my God. So this is, and so basically what it tells us is that we have absolutely no choice but to innovate in order to improve or even sustain our health system. So that was my first, the first big issue with which I was entering my mandate, with the first thing that I had behind my mind. So first of all, what is the commissioner? What's his mission according to our law? So our mission is to inform the health minister or the government and the population on the performance of the health system, and to make recommendations in order to improve that that performance. So in the face of the context or the picture that I just drew for you, we were thinking, well, if that's all we do, we're not going to improve, or we're not going to influence enough the health system, because we had observed that in the many past years, all the issues had been identified, and we haven't made much headways into improving or in introducing innovation into the health system. So we said we need to go a little bit further than just making recommendations. And that's where we decided to work on what were the obstacles to innovation, and what are the policy or institutional obstacles, and how can we help working on these issues? Because as long as we don't tackle these issues, we're always going to have a hard time innovating. And although we can invent, have the best ideas and even showcase these ideas, if we don't improve or if we don't break those barriers, then we're not going to improve much. So this is one of the most important area in which we would like to make further advancement. And the other thing is, it's in our law, but as we are doing this, we are encouraging citizens' participation. So we are in a constant dialogue with the citizens to find out what is important for them, what is the most important issue, what are the most important problem, what are the results that would make real difference for you, and also on ethical issues. So there are so many when it comes to sustainability, but I won't go into this, but this is also one main area where we're working. And then we are, well, so this is what I just said. So what are the 3 or 4 areas where we're actually having a lot of activities? The first one is performance analysis. So I don't pretend to be at the level of ICIS, but just to give you an idea of what we're doing in performance analysis is we're doing the same kind of work that the ICIS is doing. So this is really data analysis, demonstration of where are the variations, etc. We're also working here as to how does governance influence the performance of the system, which is one area where we do not find many framework to inform our work. So if you have any ideas there, we will be very open for discussion. And well, the other area would be in policy analysis. Oh, I'm sorry, in the performance analysis here, one of the headway that we would like to do, or some advancement that we would like to do, is to publish on result indicators so that we can help the innovators to start at the beginning of their own project to accumulate data on these indicators in order to show the results and help the decision making on purchasing these innovations. This is the area for policy analysis. This is the area that I was talking about just a little bit earlier. How can we improve our policies and our institution, our regulation, in order to support better innovation? Communication is a very important area. If we do not inform the population or make our information available in terms of understanding in the proper language for them to understand, we're just going to be half as efficient as we could be. So this is also a very important area. And Jane, you know, you very well established this by showing what you're doing in this area. We're not half as far as you are, but this is where we would like to go. And this is, we're slowly building our pieces towards that. And then of course, citizens' participation. Oh, maybe just to show you, this is the vision that we have of the system and towards which we're working. So we're working towards a health system, a social services and health system that would be pérenne, sustainable, agile, and performant, that is adaptable and evolves according to population's needs. Sorry for the translation. So our first mandate, so now talking about elderlies. So the first mandate that we had was just after the first phase of the pandemic. The government gave us the mandate to evaluate the performance of the government in handling and managing the first phase of the pandemic. So this mandate basically was, they wanted us to give a special look at the way we provide healthcare services in long-term care. They wanted us to look at public health and also to the governance of the healthcare in the system, but also in the healthcare for elderlies. So as I said, well, I didn't really say that, but basically we had issues that were of 4 main categories, and we had to divide these many issues because, as you know, the health system is dynamic and there's many issues that overlaps. But basically we divided them and we looked first at the, how did we manage? What was the public health capacity to manage the health, the pandemic. How could they improve themselves? The second one, the second area of findings were about the organization of cares for elderlies before they entered the pandemic. The governance of healthcare services that are towards elderlies. That was the third area. And the fourth area is how does the governance of the whole system affect the results in each and every one of these areas? So I'm not going to go and tell you all the recommendations, because as you know, these big endeavors or these big public reports can provide very many recommendations, and we actually decided not to do that because it was just going to be another pile of. So we decided to focus on what needed to be done in order to help the system help itself, in order to get improvements in the long term. So the first one is we recommended for the ministry to stop being an operator and give more attention to governance of the system. There's been a lot of lagging in the governance of the system, in the planning and the orientation, in providing support to the actors, providing provincial services so that all the actors the actors being the providers could focus on the operations. So that was the first one. The second one was the system should go from a system that is medical and hospital focused to one that is focusing on integrated services, focused on what is needed, what is important for the patients. The third area was to move from a centralized human resource management system to a management to human resources that would be managed at the local, from the local area or at the local management level, that would also focus on mobilizing the human resources and promoting their health. The third area was to move from a system that is very opaque. I think among all the provinces in Canada, the Quebec system is the most opaque. Is opaque the right word?
Very dense. It's a very dense system.
Very hard to get information. And basically it's so centered on protecting personal information that you cannot use information in order to improve the system. So basically what we're doing is that we should have an integrated, open, transparent data system to enable the full exploitation of these data, but also without compromising the privacy of personal information. And lastly, we recommended to use public health at the center of the strategies, the government strategies, in order to improve the performance of the system. Basically, right now, public health is a separate system almost to the rest of the system, and we do not use all the capacities of what public health could bring into focusing on the appropriate population and how to do it. And now, since we're talking about elderlies and elderly care, just to tell you that two of the main recommendations that we made for the elderly care was to provide a measuring system that would enable us to compare the results, follow the evolution, but a system that would be focused on the results that are important for the patient. And what else? Oh, and I just want you to understand that one of the reasons why we were focusing and making that particular recommendation very important is that we are lagging behind every province as to how our elderly care are advanced, and we entered the pandemic in that state. So that's one of the reasons why we had such disastrous result in managing the first phase of the pandemic. But we basically had talking about opportunities, which we will do later, we basically demonstrated that we were able to face the issues and address them when it was time to do that. So that was a great, it was a great learning experience. So right now we're having another mandate, and I'm going to stop after this because we haven't found, I don't want to talk about the findings just now yet because we haven't had any publications. But basically we're having another mandate that was given to us by the government, and it's on home care. And basically we need to examine, they have asked us to examine what is the financial support of the home care, and can we look at the performance of the healthcare programs. To start with, I can tell you that 75% of the home care is provided by external service organization from the public organizations. So it's already provided by many actors outside of the public services. And there are also many programs that are managed by many different ministries, but there's no overall management of all these programs or overall knowledge of what they are and how are they all oriented towards the same goal, or are they all working towards different directions? So basically we need to work on a more complementary strategies so that we all work in the same direction. So that's all I'm going to present for now, and then we can engage in the conversation, and I can focus my intervention more on the issues at hand. Thank you.
Merci beaucoup, Joanne. Thank you very much. And some key words mentioned during Joanne's share is social innovation and public participation is a big tool that we are in the findings here in Quebec, and social innovation has been going on for the past 30 years. It's a strong, very strong value in Quebec to work with population to do key findings. So this on the ground is ongoing, and now since a good 6 to 8 years now, and the ecosystem is helping us funneling the needs that Joanne has mentioned. So we are positioning the ecosystem to be a funnel of reinforcement for our commissioner and our health system to be able to intertwine and work in collaboration. Very interesting, Joanne, and looking forward to the conversation moving forward.
Thank you.
Next up, merci encore. Next up, we have Michael. Michael, the floor is yours. Thank you for being on board.
Hi, everyone. Thanks, Pascal. So I'm just going to get my slides up here. Okay, and hopefully you can see those just fine.
All good.
Okay, so hi everyone. So thanks for taking the time to listen today. Michael Krastowski. I am AGE-WELL's Business Development and Industry Relations Lead. So I work with our researchers on commercialization, our startups, but also our partners, often in industry, but also outside of industry, on kind of connecting the dots in what we do. And I'm going to give you a little bit of an overview of AGE-WELL and some of our work in this space. So to begin, first, AGE-WELL itself, we are an organization that is a little over 8 years old, and we have been funding research and innovation in technologies, services, and policies that enable those technologies that benefit older adults and their caregivers. We have been doing this through support of research at universities across Canada. To date, about 47 post-secondary institutions have been part of those projects. We have worked with many researchers and trainees, over 1,000 of those trainees, and over 250 researchers have taken part in our project. And we are also a network. So we work with partners in a range of spaces that come together to help us deliver on that mandate of improving life for older adults and caregivers through use of technology. Obviously, there's partners in industry, but also not-for-profit and community-serving sector. We have partners in academia, as one would expect, as well as in government and other stakeholder groups. And these partners work with us on specific projects, but also on network level initiatives that we work together to deliver on to enable technologies to have more of that benefit. And I should say that when we talk about technology and age tech, as we often call it, we look at this as any kind of technology that can improve life for older adults. So it could overlap with others, such as digital health, assistive technologies, and things like that. And the other part I want to mention, and especially with what you just heard from Joanne, is we look at technology and innovation as a way to assist a lot of human efforts and human-driven efforts for care and quality of life. So we're not really looking at technology as a way to replace people, but to augment and support the work that they do. And in order to do that, we do need to make sure we engage closely with those we're looking to serve. And we've had over 5,000 older adults and caregivers take part in our network. And that isn't simply as participants in studies, but we are really big on co-creation and making sure that our stakeholders are involved from the very earliest stages in the projects we fund and in the ideas that we're looking at. So to date, we've been working with those researchers, with older adults and also with innovators and startups to deliver on solutions. And our network has been able to support the development over 170 solutions to date. The majority of those are technology specifically, but as I mentioned, also the services built around technologies and different policies and practices that enable a greater reach and impact of technologies as well. So at AGE-WELL, we look at the things we do through the lens of 8 challenge areas. And these challenge areas were developed through a kind of ongoing stakeholder engagement process that started in about 2017 or 2018 is when it first finished. And we did surveys and town halls with older adults, caregivers, and different organizations that serve them to figure out what are the key challenge areas that older adults and their caregivers face. And now a lot of these have some overlap. And when it comes to aging in place, you would imagine supportive homes and communities, things like autonomy and independence, staying connected, which is the flip side of social isolation, and healthy lifestyles and wellness. All of these are relevant to that and the other ones as well. And so when we fund research projects and even when we work with startups, we try to identify which of these challenge areas are being addressed and how are they being addressed. So I want to put just a couple of I guess stats that we collected through an environics poll we commissioned. We actually did one in 2019, and then after the pandemic had begun, we did another poll again in 2020. Where we found a whole bunch of different aspects of attitudes on technology for older adults. And some interesting findings that I listed here were that more older adults were confident in their ability to use technology in some way than a lot of people would typically think. And I think that's changing all the time, especially after the pandemic. But also we found a surprising number were looking or willing to even pay for technology that could support their ability to age in place. And not surprisingly, this number increased during the pandemic when there was a lot of challenges that were visible, very visible in the media and elsewhere in other settings outside the home for older adults. So for AGE-WELL itself, we fund research across the board, as I mentioned, across those challenge areas. And what we've been able to do is sometimes develop technologies directly from research we funded. An example that I listed here is Virtual Gym, which is a technology that allows people to work with an occupational therapist or even on their own and do customized and tailored exercise programs at home or in other settings, which became relevant especially during things like lockdowns and reduced ability to take part in other kinds of exercise settings. We've also worked with startups to help validate their technologies An example here is Braze Mobility, which developed a sensor system for assistive devices and specifically powered wheelchairs to help people feel more comfortable and have greater autonomy and independence when they get around in different settings by utilizing the different kinds of sensors around the wheelchair itself. And then when we look at aging in place, we're talking about a whole bunch of different things. Sometimes, how can we better design living spaces to make them adapt better to us as we age? But also, can we utilize technologies to still live within spaces where we've always been aging, but facilitate things like getting laundry upstairs using a stair climbing robot? And we continue to fund research in this space. Right now, we are funding some core research programs, and examples are those in social robots, smart home technologies, and how to better leverage those for older adults, telehealth for remote communities, obviously became quite relevant during the COVID pandemic, and continues to be so, especially with greater challenges in the healthcare space. And also things like preventative measures. So to the presentation we just heard, obviously when we think about increasing the health span, that can potentially help to reduce costs of healthcare later on and acute healthcare costs, or at least reduce the window during which those costs are higher. And there's technologies that can enable some monitoring and recommendations around healthy lifestyles as well. So as I mentioned, we're also a network, and we often like to see what perspectives we can get from other stakeholders in our network. One thing that we did during the pandemic is we brought together a working group of partners in industry, and this included partners from things like home care, but also in those tied to delivering medical devices, those providing telehealth solutions, and of course we also included the voice of older adults and caregivers in that working group as well. And what we were able to do is try to see from industry's perspective, how can this tech-enabled home or technology to assist aging in place, how can it be better done in the future? And our goal ended up being to see what recommendations could industry and this working group make for innovators, startups, and those in industry that are looking to address this space. And the working group ended up coming up with 5 kind of key overarching themes. One is to ensure user-friendly technology, also to see to what extent we can make these technologies intelligent, and that obviously tied to one of the other points on being ethical means that we have to both try to enable that, but still respect those concerns around privacy and data ownership that are always key for everyone, but definitely for older adults and their caregivers when they are present. And then staying connected is important, but in terms of technology, that can mean connecting to your circle of care, social groups, services, but also to make sure that technologies within the home can be interoperable and more integrated. And yeah, those pieces led to a white paper, which can kind of help inform those innovating in this space, especially those in industry, and getting the voice of industry to kind of validate some of those ideas was very important for us. So I mentioned earlier that we work with a lot of different innovators, including with startups. And what we have been doing regularly is trying to see across Canada what startups are active in different challenge areas that we have validated with older adults and other stakeholders. And what we're seeing, especially during the pandemic, is there are more and more innovators looking to enter the space and also deliver solutions for areas that are important for aging in your home and healthy aging in general. And it's really promising to see more of that happen, especially in light of the pandemic and the increased preference for aging in place. So just my final note is more kind of forward-looking for AGE-WELL. What we really want to do is to continue to support the research and development of these solutions, the technologies, but also the things that enable them, whether it's services or policies and practices. But we also want to increasingly do a better job of seeing how can we effectively implement and scale these solutions. And I think that really resonates with what was already presented to you today. We want to make sure that technologies and innovations that have been piloted or that have been demonstrated in one space can in the future be brought into other places and replicated. And so we're developing more programming and working with partners at the national level to figure out ways to support that better scaling and implementation of technologies. And hopefully we'll be able to launch some exciting initiatives in the coming year around that. And that is it for me. Thank you.
Thank you very much, Michael, and thank you for being on board today and sharing, again, knowledge from AGE-WELL and what you guys are doing. Always very impressive. And another area of focus I think we have in common, all of us today, and our audience, is challenges when it comes to broader territories and engaging in getting, being able to get healthcare to communities that are out there and do not have access, rather it be from mobility perspectives or even technical and technology perspectives, because as we know, literacy is a big issue that we've had in our findings as well, and there's digital literacy issues and illiteracy challenges as well. When we look in Quebec, and it's part of the campaign right now, we are in a political campaign, and the illiteracy issue in Quebec is another challenge that we need to cope and be able to better find ways to reach out to the population with these challenges as well. So thank you, Michael, again for your presence. We are moving forward in our second half of our webinar. So I will invite, I think, Jenna, we are with Constance now, is our fourth, right? And finishing.
Yes.
Thank you. Constance, the floor.
Oui, bonjour. Alors, Constance Vanny. Je pense que vous voyez maintenant mon écran, c'est ça. Oups, alors, je vais revenir un peu en arrière. Alors, Constance Vanny, je suis... vous voyez bien mon écran?
Oui.
Oui.
Bien,
okay, parfait. Directrice santé communautaire pour le Québec à la Croix-Rouge canadienne. Ça me fait vraiment plaisir d'être avec vous aujourd'hui. Alors, moi, je vais vous présenter un projet très concret qui s'intitule Projet Proximité aînée. Alors, la présentation va se faire en français. Si jamais il y a des questions, ça me ferait plaisir d'y répondre en anglais aussi. Là, il n'y a pas de problème. Et la présentation, les diapositives sont dans les deux langues, anglais et français. Donc, vous ne devriez pas avoir de difficulté à suivre. Alors, peut-être un petit mot sur le contexte. Alors, vous voyez là, as you can see, the slides will be like this. There's going to be a French on the left, and on the right, you'll see the English portion. So it should not be a problem. Donc, d'abord, un petit mot sur le contexte. La pandémie, on en parle beaucoup, la mis en lumière la grande vulnérabilité de nos aînés. Et les chiffres que vous voyez à l'écran sont révélateurs. J'ai mis des statistiques pour Montréal parce que le projet actuellement, il est à Montréal. Alors, plusieurs aînés sans médecin de famille, avec des incapacités, un faible niveau de soutien social et plusieurs vivent seuls ou loin de leurs proches. Alors, ces réalités font en sorte qu'il y a plusieurs aînés qui ont peine à faire leurs activités de tous les jours, vivent de la solitude, de l'anxiété et aussi plusieurs maladies physiques ou mentales. Puis ces conditions de vie ont été exacerbées évidemment par la récente crise sanitaire et requièrent des gestes concrets pour soutenir les aînés dans leur milieu de vie, dans leur communauté et prévenir leur déconditionnement. La Croix-Rouge, par sa mission de venir en aide aux personnes vulnérables, par son expérience aussi auprès de ces populations vulnérables, a mis sur pied à l'été 2021 le projet Proximité aînée. Alors, le projet, c'est la mise en place d'un système d'identification des vulnérabilités chez des personnes aînées vivant à domicile, permettant le référencement assisté vers des services de proximité cliniques et communautaires. Donc, vraiment, c'est de faire des ponts entre la personne aînée et les acteurs du milieu de la communauté, incluant les organismes communautaires, les services dans la communauté et aussi le réseau de la santé et des services sociaux. Et ça, on le fait en complémentarité avec les acteurs présents et de façon personnalisée. La clientèle, les aînés de 65 ans et plus qui vivent à domicile et qui n'ont pas de médecin de famille. On a vraiment focusé sur cette clientèle-là. Et à ce jour, elle est référée par le réseau de la santé et des services sociaux et quelques pharmacies. Alors, on reçoit la clientèle à partir des guichets d'accès à un médecin de famille. Alors, on les appelle les GAMF au Québec. Et on a focusé sur on a mis l'accent sur 2 CIUS actuellement à Montréal, le CIUS centre-sud de l'île de Montréal et le CIUS de l'ouest de l'île de Montréal, parce qu'il y avait une grande concentration d'aînés sur les listes d'attente de ces 2 CIUS-là, entre autres, et des aînés qui attendent pour un médecin de famille depuis plusieurs années. On parle de 3 ans et plus. Alors, on a commencé avec cette clientèle. Les objectifs, évidemment, toujours dans le grand but d'avoir les aînés vivre le plus longtemps possible en santé et sécurité à la maison. Alors, objectif, contribuer au maintien de l'autonomie et du bien-être global, prévenir la dégradation de l'état de santé, réduire l'isolement social, faciliter l'accès à des soins de santé ou de services sociaux et services communautaires et diminuer les risques de visite à l'urgence. Les actions. Eh bien, il y en a 4. Première, approche de concert avec les partenaires de la clientèle en attente d'un médecin de famille. 2, identification des besoins des aînés participants. 3, référencement vers des ressources cliniques et communautaires. 4, l'accompagnement personnalisé. Alors, les 2 premières, on voit que les 2 premières actions sont vraiment en amont. Donc, c'est des interventions préventives en amont pour essayer de rejoindre la clientèle et d'identifier des facteurs de vulnérabilité. Et les 2 autres, la 3e et la 4e, sont des interventions d'arrimage pour faire des ponts avec des services de proximité pour répondre à leurs besoins, et ce, de façon personnalisée avec un suivi. Le processus, alors, c'est une illustration du processus du projet Proximité aînée. Alors, comment ça fonctionne? Comment ça marche? Alors, d'abord, le personnel administratif des guichets d'accès pour avoir un médecin à la première ligne du CIUS va communiquer avec la clientèle qui sont en attente de 65 ans et plus, qui sont en attente pour avoir un médecin de famille, et leur propose le projet Proximité aînée, donc l'aide de la Croix-Rouge pendant qu'ils attendent pour avoir un médecin de famille. Si l'aîné, ça répond à ses besoins, s'il consent, ses coordonnées vont être transférées à la Croix-Rouge. Après, c'est des bénévoles dûment formés qui vont communiquer avec l'aîné. On réexplique le projet, si ça répond aux besoins, si c'est bien ce que l'aîné a compris et s'il consent. On va administrer un questionnaire qui est le questionnaire ESOGER, qui a été développé par Dr Boucher et l'équipe du Centre d'excellence sur la longévité de l'Université McGill, qui est un questionnaire qui va identifier des vulnérabilités sur le plan socio-gériatrique, donc des facteurs sociaux, de la santé, des facteurs cognitifs et psychologiques. Et ce questionnaire va donner des résultats qui vont nous indiquer par la suite comment assister l'aîné dans différentes trajectoires de proximité. Alors, le bénévole va discuter avec l'aîné, va administrer le questionnaire et va aussi demander quel est le meilleur temps pour rejoindre l'aîné. Donc, c'est pour ça que je vous parlais d'une approche très personnalisée parce qu'on prend beaucoup de temps pour écouter l'aîné. On peut faire plus qu'un appel également et on va rappeler l'aîné au moment où ça lui convient. Ça peut être le soir, ça peut être l'après-midi parce que le matin, l'aîné va dire « moi, je préfère écouter des émissions de télévision, etc. » On va vraiment adapter le tout en fonction de ses besoins. Par la suite, il y a un analyste qui va rappeler l'aîné rapidement et en préalable va avoir déjà fait des recherches sur quels sont les services à proximité du domicile de l'aîné pour répondre aux besoins selon le questionnaire. Et l'analyste va valider les résultats du questionnaire avec l'aîné, va voir avec l'aîné est-ce que ça répond à ses priorités, ses besoins, son projet de vie, et va voir s'il y a d'autres besoins aussi. Et il va enclencher ce qu'on appelle la trajectoire communautaire avec j'ai mis quelques exemples, des organismes communautaires, ça peut être l'entretien ménager, ça peut être de l'aide alimentaire, du transport, de l'accompagnement, de la formation sur la technologie, etc., ou même des organismes qui vont accompagner l'aîné pour avoir accès à ces services-là. Alors, tout ce qui est vert, en vert ici, c'est les trajectoires communautaires. Si dans les résultats ou lors de la discussion, on s'aperçoit qu'il y a des besoins au niveau de santé, on propose à la personne de parler à notre infirmière de liaison qui est à même l'équipe du projet Proximité Aînée à la Croix-Rouge. On propose de lui parler. Alors, si l'aîné accepte, c'est l'infirmière de liaison qui va rappeler tout de suite après pour voir c'est quoi les besoins et potentiellement enclencher une trajectoire clinique avec la Croix-Rouge. Alors, je vais vous donner un exemple. L'infirmière peut, à elle seule, avec nos services à nous, en télépratique, peut régler à peu près 50% des besoins semi-urgents, tels que la gestion du poids, du sommeil, des difficultés peut-être avec certains médicaments, l'alimentation, l'équilibre, des petits exercices qu'on peut faire à la maison, etc. Elle peut également faire des références aux cliniques de groupes de médecine familiale réseau avec lesquels on a des partenariats pour faire des références en gériatrie pour des consultations spécialisées avec lesquelles aussi on a des partenariats. On peut aussi maintenant, depuis à peu près la mi-juin, faire de l'accompagnement pour des références vers le nouveau guichet d'accès à la première ligne. On a développé 2 formulaires avec les SUS et l'infirmière peut d'ores et déjà faire un premier triage et indiquer si on a besoin d'un travailleur social, d'une nutritionniste, d'une infirmière praticienne spécialisée et même d'un pharmacien. Donc, le formulaire, elle peut pré-identifier les besoins, ce qui facilite la fluidité vers le guichet à la première ligne. Il faut comprendre que souvent, en discutant avec la clientèle avec qui on a affaire, parce qu'on travaille avec les clientèles les plus vulnérables, les gens ne savent pas quoi faire souvent avec le guichet d'accès à la première ligne, ne savent pas comment communiquer avec ce guichet-là. Donc, nous, on va les aider à faire les prises de rendez-vous et avec les formulaires, on a déjà quelque chose qui peut aider dans le référencement. Oui, c'est ça. Alors, je dirais que 65% des cas sont réglés par l'entremise de notre infirmière et 50%, elle le fait à travers juste ses conseils cliniques. Alors, des premiers résultats fort intéressants. Alors, ça fait à peine plus d'1 an qu'on est en opération. Au niveau de l'approche de la clientèle, bon, le côté anglais devrait... Voilà. Ça ne devrait pas tarder. Alors, l'approche de la clientèle, 1884 références reçues jusqu'à présent, 2921 appels faits par des bénévoles de la Croix-Rouge, 1138 appels faits par l'infirmière et les analystes, 503 aînés qui sont suivis qui bénéficient de suivi périodique. Bon, ça... Petit problème ici. Alors ici, je vais juste attendre un petit peu pour que les gens puissent lire en anglais la partie des références reçues, des appels faits par les bénévoles. Ici, il manque un petit mot, là, calls made by volunteers, et les appels faits par l'infirmière et l'analyste et les personnes suivies par qui bénéficient de suivi. Je le mentionne parce qu'en plus des trajectoires, ce qu'on s'aperçoit qu'on n'avait pas prévu, c'est que les appels et les suivis font partie des services fort importants. Il y a des gens qui ne sont pas dans les trajectoires, mais nous disent « appelez-nous et suivez-nous, j'aimerais ça qu'on ait un autre appel ». parce qu'ils sont pas tout le temps, ils disent pas tout le temps avoir des besoins tout de suite, mais ils disent on pourra peut-être avoir des besoins plus tard. Donc, on aimerait que vous nous rappeliez. Au niveau des services requis, bien, clinique, je vous en ai pas mal parlé là, tout à l'heure dans le processus. Alors, au niveau des services cliniques, vous les avez ici. Au niveau communautaire, les principaux services communautaires, c'est l'entretien ménager, le transport. Je pense que les conférenciers précédents en ont parlé aussi. Les appels amicaux, les gens ont beaucoup besoin d'appels parce qu'ils vivent beaucoup d'isolement et de solitude. Et la formation numérique, on nous rapporte, en tout cas de notre côté, des difficultés avec transiger avec l'Internet pour faire des rendez-vous, pour remplir des formulaires. Alors ça, c'est quelque chose qu'on nous rapporte comme un besoin. Dans les trajectoires, on a 537 aînés dans les trajectoires, dans les répartitions suivantes, 47 en trajectoire clinique, 24 en trajectoire communautaire et 29 en trajectoire mixte. Un exemple concret, alors vous avez 2 témoignages ici. Alors c'est une dame qui vit seule en résidence privée avec certaines maladies, mais en discutant avec elle, on a aussi d'autres choses qu'on s'est aperçues, c'est-à-dire des pertes d'équilibre et de poids et son isolement social qui avait un impact significatif sur son quotidien. Alors voyez-vous, comme c'est tout cet élément-là qui a été rapporté, on ne l'aurait jamais su si on n'aurait pas parlé à la personne. Alors, ce n'était pas documenté. Elle a pu donc, avec notre projet, elle a pu bénéficier d'une trajectoire communautaire avec un service d'entretien ménager dans la communauté et des appels amicaux, ainsi qu'une trajectoire clinique avec un référencement vers notre service de gériatrie. Alors, vous avez un beau témoignage ici. Je me suis sentie écoutée et comprise. Il y a beaucoup d'écoute. Les choses ne se sont pas précipitées. Je suis satisfaite, etc. Et notre gériatre qui dit que c'est un exemple parfait d'une initiative efficace et efficiente et rapporte qu'on a pu avoir une prise en charge globale et une consultation en moins de 2 semaines. Un petit mot sur la recherche. Le projet fait actuellement l'objet d'une recherche sur les impacts du projet, donc les objectifs dont je vous ai parlé au début, font partie de la recherche actuellement, qui est financée par le Fonds de recherche du Québec santé. Et les résultats vont être connus en décembre 2022. Alors, je vous remercie beaucoup. Alors, merci pour l'attention. Et s'il y a des questions, et puis quand on va discuter ensemble, ça va me faire plaisir de partager.
Merci beaucoup, Constance, pour le partage de la Croix-Rouge. Thank you very much, Constance, for this Canadian Red Cross sharing and things highlighted. Volunteering, I think that's a big one that touched the heart. That we need to be able to educate more and more the population to get back out there and volunteering. I think that's a big role we need to play everywhere. It concerns all of us. Merci encore, Constance. Lots of thoughts there. Andy, now we're moving on to our partner in Europe from ECH Alliance. Andy, my friend, the floor is yours. Welcome. Thanks for being there.
Merci, Pascal. Merci. Thank you very much. I would just like to raise that last week in the BBC in England, they had this fascinating article that says many people retain French from when they learned it at school. They lied. I retain absolutely nothing when I actually listen to French being spoken live. I can pick out the odd word, but your slides, I have to say, were perfect because the simultaneous translation was perfect. Today, with the magic of AI, artificial intelligence, I will translate simultaneously into English with my slides. With a perfect word-for-word translation only in English, I'm afraid. However, I will share my slides in French, if that's okay, to share with you, Pascal, and colleagues from across Canada who speak French, because we have these already. There's so many things I've heard today. I've got some presentation slides. Slides are okay, But I just like to think we're here as a connector. We've talked today a lot about connecting up the dots. Okay, let's connect some dots now. We've heard from the Red Cross in Canada. We're a member organisation. We also, one of our members is the Red Cross in Australia. So let's connect up some dots there, because that's what we do. We've heard some excellent examples from our ecosystem leads with Michael, who's got some fantastic opportunities available across Canada. And then within the specifics of New Brunswick, which I had to Google where exactly it was. I might as well be honest. I had to Google.
Well, Hurricane Fiona probably taught you a little bit of that too.
Google's really good for these sort of things. So I Googled what that. I just thought there's so many examples there. I put them on Twitter, some of the examples where we can connect up with similar pieces of work across our network. What is our network? We're a connector. We are a member organisation. The good news is if you're a not-for-profit, public body, government body, university, hospital, charity, patient group, you can join us for free. I'll put the links in the chat function to share in the follow-up for this. But that's what we do. We connect up our members. We have some companies join us as well. So let me share some slides, because I promised you some slides, and I know I end up talking, and I usually end up forgetting to share my slides. So I've got some slides here in English or Scottish, as you might want to see. So, okay, a little bit about who we are and where we are. And then I want to give some practical examples, because today I want to talk about where we can connect up. We already connect up, as Pascal says, our ecosystems in Canada with those in Finland. But our network goes beyond that. We want to be able to help share and learn lessons. We want to stop people reinventing the wheel. I also want to test, if I can, give you an idea of how we can escape from the fear that our country or our region is lagging behind everybody else. Here's the good news. I'm going to stop sharing my screen because I think this is actually it's much better to have this face to face. The good news is I lose track of how many countries say, oh, we're the laggards with digital health, or with senior care, or with aging in place, or AI. You're not. Everybody else is on the same curve. You're just a little bit further above or beyond them. So one of the nice things about having a network of ecosystems is we can share good practice from what's happening here with Australia, with New Zealand, with Argentina, with Finland, with France, in French, you'd be pleased to know as well. Because they've all got the similar issues that you talked about today, whether it's from the Red Cross or again in New Brunswick, or what Michael was discussing earlier on, or the work that Numana are doing as well as the other pieces within AGE-WELL. Let's go back to those slides, because I did promise you I would share some slides. Pictures are much more important than me ranting on about sharing technology. So we connect up our members in a network of what we call ecosystems. Okay, ecosystems isn't a new concept, but we've been doing it for about 11, nearly 12 years now. We have around 950 member organizations. About 95% of those are free to join, so they're not for profits. There are 290 universities, there are 120 hospitals, there are 150 government bodies, there are 90 patient organizations, there are about 60 companies. It's about 120 networks and associations, all different sorts of organizations. They join us because they want to connect. Okay, we ourselves are a not-for-profit organization based both in the Republic of Ireland and in the UK, but we're global, and we'll talk about where and what we do now. People join us for the reasons I say here. You can see a link here at the bottom of the screen. I should share it in the chat function for you to hopefully for the organisers to share for colleagues who've joined us today. People join us because they want to promote what they do. They want to promote what they need. They also want to make connections. They want to get involved with funding. And many of you have been involved with funding projects with some of our project partners too. We also get speaking opportunities. So today we're involved with the UN Global Assembly that's happening in New York. We've taken a delegation of our members there to talk about digital health. But people come together mostly because we want to get them together in ecosystems, okay? Our concept of ecosystem is very basic. It's leading with a need. It's matching need and solution. It's about breaking down silos, as Pascal referred to earlier on. It's about transforming healthcare delivery, in this case, around aging. It's around creating economic growth. But I'm going to go backwards. It's about leading with a need. So we put patients and citizens and carers at the center of our ecosystems. That enables us then to be able to think about where we can then connect up that need from country to country to country, because that helps create international opportunities around the economy. You can see here our ecosystem concept welcomes all companies and patients, citizens and hospital providers, because without those, it's a talking shop. Now, in the field of aging, all of the ecosystems that are part of our network are involved with and specialize in the field of aging in some way or form. Now, that's rather a bold claim, but that's come from experience. I know that because I joined the first one. My involvement was around aging then, back in 2011, 2012. What that enables us to do is to connect up you and your research opportunities, or you with your technology solutions, with similar organizations to create soft landing zones for your companies in other countries and internationalize them, or to seek best practice from other countries to help better connect you with not just the best practice, but sometimes the mistakes that people have made around aging. And we've made a lot of them across the globe. Sharing mistakes stops, we think, people making the same mistakes again. That's a vital, vital clue. So our network has grown into a large network of ecosystems that you can see in front of you. And it's growing all the time. So just in the last couple of months, we've announced our newest ecosystem in Africa, in Zimbabwe. Our ecosystem network stretches from Z to A, all the way over to Argentina, all the way over to Australia, as we've talked about just now. And we hope soon, with more ecosystems opening up in New Zealand, Australia, India, and Africa, to bring a truly global approach to some of the issues that affect us all globally. And aging's one of those. Just in this last month, one of our commercial members approached us to say, what other connections do you have within your network that specialize in aging well and aging in place? Immediately, I was able to talk about the work that Michael's doing with the ecosystem, the cross Canada ecosystem that they've set up with AGE-WELL. Immediately, I was able to point across the globe to the work of the Australian version of the same thing, or in Scotland, or in France, because those best practice examples are ones we want to feature because they're our members. What that's also enabled us to do is to build a series of what we call thematic ecosystems, which then looking at separate topics like aging, but on a topic by topic basis, whether it's to do with skills, life sciences, mental health, etc. We haven't started one yet on aging because I think enough of our ecosystems are involved with this on a day-by-day basis. But I still think there's an appetite to do that sharing across border. Now, let's go back to the challenge we've got, which is we're a connector. So we want to be able to connect up the best that we see within Canada across the rest of our network and vice versa. Why we want to do that is quite simple. I have been involved with healthcare since my involvement with psychiatry 30 years ago, and we're still reinventing the wheel. We're still working in silos. What our network's able to do is to share from country to country that opportunity to learn from mistakes, from best practice, to share need and opportunity. So my invitation and call for action today is to say, where can we take the best of what we've heard from our panelists today and project that across the wider part of our network? Because assume this, you might think everyone knows what you're doing within New-Brunswick or in Quebec or across Canada, but they don't. Many of you today wouldn't have heard of some of the speakers today. Joining our network means you're better able to make those connections, whether it's around aging, whether it's around working with senior economy, whether it's to do with the industrial economy that can come, the opportunities from that network. Only today, one of our newest members was asking us around, from Portugal, how can we extend their connectivity from Portugal around the field of longevity and the longevity economy, not the silver economy, but the economy around longevity. So always the boundaries are moving. This network helps to keep up. You can sign up for our newsletter. You can follow us on LinkedIn. I'll put the link in as well. But join us, because we're a connector. That's what we do. As Pascal said, and I shall end now, we first met to do with connections with Lauria in Finland. Our connections from Lauria in Finland are now linked to our ecosystem in Helsinki, are now linked to our Australian ecosystem in Melbourne. And now we come full circle back to Canada. Aujourd'hui. Merci beaucoup. Back to you, Pascal.
Andy, thank you very much, and to everyone. Andy is always available if you want comparables of your models and to see what's going out there in the world. Please reach out to Andy in the ECH Alliance, because he's got more than one up his sleeve. And if you want to talk about jazz as well, he's very, very strong, and yeah, a lot of conversations on jazz and Sesame Street, but we won't go in there, Andy.
No, Bert. Okay, thank you.
Thank you, Andy. Thank you, everyone, for hopping in today's conversation. We are walking into the last 20 minutes or so, and we were ambitious, Jenna, and which is good, because we wanted 2 questions from our invitees today, and a little bit of room as well if our invited people, participants, would like to ask questions as well. We would like for them to be able to express themselves. So if I can propose to everyone is to basically ask one of the questions you sent our way, and yourselves answer this question, not going into a bigger conversation because of time elements, but I think we would have, sufficient content to speak for a full day, or even go away somewhere for a full week and work on all of this. So I'll jump right in there with the questions that we asked our invitees today, if they wanted to ask a particular question to answer. So I will come back to Jane. Jane, one of the questions you sent our way, and this is one I'm proposing for you to answer, is the next one. So your question for all, in the context of sustainability, what have you and your team learned, and what are you doing now, and what would you be doing as far as more inspiration for the future? So basically, in the context of sustainability, Jane, what is yourself and your team have learned within the project, the pilot project?
No. Well, I have to say, excellent question, but that's so in terms of sustainability, I can take myself back to when we initially put out the call for proposals, because at the very beginning of HSPP, I was with the Department of Social Development and developed the design of HSPP in the call. And we had in part of their question, like, how would you sustain the pilot project? And I think we were asking an unfair question at the time of all the researchers. And so when we got to the stage of projects being implemented, seeing some go through to completion, we said, we really need to pay attention to how is it that we can help projects identify what some of their plan could be for sustainability. Because if you ask a project at the very beginning, it's going to change throughout. So what we're doing now and what we're doing differently is that we're setting projects up to succeed by providing them with the tools of how to develop a plan, how to, like, what are some of the key areas that they need to pay attention to, and so that they're aware of how to do it. So that's one bucket. It's almost like a three-legged stool, I would say. There's that bucket, and that's education and support. There's also ensuring that the funders and the potential target audiences are aware. So that's the information, so that this doesn't come as a surprise to them. So we have that collective information that we can ensure gets out there. So that's that second leg. And the third is also, how do we help promote any potential funding opportunities? Because there's a plan, there's the funds, and there's awareness. So I think that what we're doing is we're looking at it from that perspective. And so if I had my time back, we would have had that, that strategy at the very beginning. But it's like, I think most announcements, we were almost building the plane while it was flying. And so at this point, we're at the stage now that we can take our time to say, let's help support projects in this way.
Thank you very much, Jane. I'm taking the opportunity, since we have some time. Does anyone of our invitees would like to connect the dot on what has been shared with Jane, or should I move forward with questions? I'll move forward with questions. Thanks again, Jane, for this question. Joanne, addressing this question that you shared to us, and it goes like this. How can we improve our healthcare system to produce more value for the elderly? Oh, your microphone, you're still off, you're mute.
Thank you.
Yeah.
Thank you. Sorry for this.
It's okay.
I would say that the short answer would be to focus on producing results that are important for them. So as opposed to try to solve all issues that we may think that may be important for them, to really focus on what is important for them. And at the system level, it would be essentially what I presented in my slides, and it would be essentially changing the system from a system that is focusing on activity to one that is focusing on value, to make information more available, a system that is more transparent and uses data while protecting private information. The other thing was making human resources management one that is more focused on mobilization, one that is also and on their own health needs, and also managed locally. So I would, there are many things, but the five main, and the public health system, using more public health in order to improve healthcare before the problems arise.
Thank you very much, Joanne. And something you have mentioned, and you mentioned in your presentation as well, is the fatigue of our workforce in Quebec. And I think this is global. I think we're going through global post-pandemic fatigue, and during the pandemic as well, fatigue and other health and mental health issues erupted. And this is data as well that I think we need to be able to better understand, and the impacts of the health workforce as well within this pandemic and post-pandemic. So thank you again, Joanne. Very thoughtful reflections again. I'm moving on to Michael, and Michael, your question was one of your questions was, and it goes as follows: what role can tech play to support aging in place? So, Michael, what role?
Sure. Thanks, Pascal. I just wanted to quickly comment on what Joanne was saying now. I definitely agree with her presentation, with your presentation, Joanne, and what you said about also integrating other supports just outside of acute care settings. And just kind of in the spirit of what was mentioned today, it would be interesting, I think, for all of us to hear about how other jurisdictions have looked at integrating care, whether it's social support services with healthcare and others, and understand that better. I know here in Ontario, for example, there's more work with Ontario health teams and trying to see how we can integrate that, but there's always going to be the challenges of a lot of budget allocated to hospitals. And like you said, we also need to look at the proactive preventative measures to reduce those costs later. And hopefully through these connections and conversations, we can also learn more through Andy and others about what others are doing in this space, because it's still an open problem and a very pressing one. So thanks for your input on that.
My pleasure. I would love to talk more about it. Of course, there's so much into this because we have to rethink the relationship between the actors so that we can make it useful for the patients, or I shouldn't call them the patients, for the people. Anyway, I'm open to further discussions.
Great. Thank you. And Pascal, as for your question, I think there's a lot that can be said for the role of technology and aging in place. I'll try to be brief, just to kind of reiterate what I mentioned before, in that I think technology has that ability to support people, and whether that's the person living in their home. So for example, we've seen technologies that can help you, connect with family members, but also those that can help you control devices and lights and things around your home, so that you have that greater feeling of autonomy, even if, let's say, you develop issues with mobility. Technology can sometimes help with certain aspects of safety. So whether it's smart lighting at night to reduce the risk of falls, or even maybe alerting family members or caregivers of a potential issue. And in some cases, maybe even if we're getting into AI and something really fancy like that, maybe even looking to predict what kind of health issues may arise later on. And I believe there's even some work in a smart home research that's being done in Quebec that AGE-WELL has helped fund, that tries to look at that and tries to be more proactive. Now, the one caveat I have to add always is, while we do that, we have to find a way to do that while respecting privacy and issues with data. I mean, that's number one concern when we talk about bringing monitoring into someone's home. And we want to find a way to do that while making people feel comfortable, but still feel supported. And I think communication around technology will be a big piece. It's not just designing these solutions, but I think someone said earlier, looking at the needs first. So yes, understanding what the actual needs are and communicating, working with those people looking to age in place, so that we can present it the right way. Because otherwise you'll have some really innovative solutions that no one is willing to adopt. So I'll end with that.
Thank you, Michael. And your words resonate throughout the pandemic, and the ecosystem here in Quebec, and the living labs in progress, and funding from the ecosystem is in industrial design. There's, the first step is empathy, and it's always almost all the time forgotten in industrial design. Now moving into social challenges as aging in place, and in caregiving and other social challenges, where we're seeing empathy design being a strong tool, being able to foster the data, being in an agnostic process, and then being able to better identify the technology once that journey has been designed. So we're mapping more and more of these tools around using empathy design, and seeing what technology can be bridged. And it's interesting what we're going to be able to seek and be able to see from the ecosystem and the work going on in Quebec in different areas across the province as these living labs move forward. But I wanted to mention the empathy part. It's something that came out very strongly during the pandemic, and although because of distance and and we couldn't get in touch with each other. It has brought these tools, these social innovation tools, to be accelerated. So I mean, a good win from the pandemic is the use of these tools to being able to better identify the correct technology. So here in Quebec, there's advancements a whole lot around that, and the actual the ecosystem of the empathy ecosystem around the individual going through his journey. We're seeing tools as well being able to identify where the person goes on a daily basis to be able to get support. And it's way beyond community, family, and even neighborhood. There's different areas that we would not have been able to see if this pandemic had not arrived. So there's a lot of strong points throughout of this. So thanks again, Michael, and looking forward to connect some more again throughout this year and years to come. It's always a pleasure to have you on board. Thanks again. Constance, moving to you with a question that you sent to us our way. So here it goes. What are favorable conditions in the health and well-being of the elderly in the community? So again, what are favorable conditions towards health and well-being for the elderly within their community? So Constance.
OK, oui, je vais le faire en français, mais je vais aussi traduire. Oui. I'll try to translate briefly. Je pense qu'il y a trois grandes catégories de conditions qui sont en fait des conditions qui préviennent les facteurs de risque. So, three major types of categories of conditions that are actually preventative measures that are preventing risk factors for the vulnerable elderly. Donc, la première serait des mesures pour contrer l'isolement social, la sédentarité et le déconditionnement chez les aînés. So, measures that are increasing social contacts and physical activity in the elderly, I think. And we can think of all kinds of activities in that area. Donc, and they can be mixed together and achieve the same goals. Deuxième catégorie de conditions favorables, je crois que ce serait des mesures qui visent l'inclusion sociale. Alors, on peut penser à des activités de bénévolat chez l'aîné parce que c'est très valorisant chez l'aîné de retrouver des activités occupationnelles et de se sentir valorisé et utile à la société. On peut penser aussi à du transport, l'accès au transport, l'accès à du transport adapté à ses besoins aussi, du soutien à domicile. Alors, l'accès à des services pour soutenir à domicile, ils sont sur des listes d'attente, c'est fort important. So the second type of category of conditions for the well-being of the elderly are measures for increasing the participation in the community. So it's access to help to stay in their home, to participate in community organization as a volunteer, for example, access to adapted transportation, etc. La troisième catégorie de conditions que j'appelle, c'est des mesures pour repérer, accompagner et soutenir. Souvent, l'aîné ne va pas chercher le service. Hein. Vous savez, on est tous des gens de notre époque et l'aîné va attendre avant d'aller chercher un service. Ils vont nous dire souvent, j'en ai pas besoin tout de suite, je vais voir pour plus tard. So we have to have measures that will reach out to the elderly, will accompany them to access services or resources or activity and do some follow-up. So je pense que j'ai résumé un peu les trois catégories. I've done this briefly and summarize those three types of conditions, but I can talk about it more and more, I'm sure.
Yeah, yes, very much so, Constance. Don't I mean, if you want to reach out to Constance on and what is interesting, what you're sharing again here, Constance, is the global aspect of the global health of the individual, which is a strong key in taking care of the four pillars of our global health. And being able to demonstrate that today is something that resonated again here in your answer. Thanks again, Constance, for jumping on board today. Andy, your question, one of the questions you sent our way, and it's interesting because you had an economic ingredient in there, which is interesting. So your question, Andy, was how do we make the economic case for wellness service rather than illness service to help people live where they choose longer? Andy.
I put that question deliberately because it makes people a little bit grumpy sometimes. And I like that because it makes people think. I've seen many countries talk about an impending bubble of aging, of a burden that's going to come down the line in 5-10 years time. And that's going to increase costs. But never have they thought this is a massive opportunity. We're going to spend an enormous amount of money on treating, working with, supporting people as they age in place or at home or in hospital. Why do we see that as an opportunity to invest? Let me give you, and I always think these things are best told with stories, okay? Because stories are nicer than slideshows that I can put up. We work with many governments around their health economy. It's no surprise that in many of the countries that we work, the health department, the Ministry of Health, has no connection with the economy ministry. They don't even know who they are. They work in, not in silos, but in completely different countries. Until you turn around to say to the economy department, who's the largest employer in your region? Where's the largest area of spend in your economy within your region? Most countries, with a few exceptions, we won't go into those. Most countries spend more on health and education than they do on arms. Most of them, okay? But we don't see that as an economic opportunity. We see that as a burden. So if your largest spender, your largest employer, your largest recruiter is your hospitals or your care providers, why don't your economy ministries or ministries for the economy have a client manager for the health department? We wouldn't do it. We wouldn't never see the relationship between the economy and health. So those countries that get it right see the other way around. They see that by transforming what is essentially an illness service, health, into a wellness service, they can create economic growth. They can create economic opportunity by creating the actual conditions, by giving people smart ways to improve their health. They can reduce the tax burden, but also create economic opportunities as well. Countries like Finland get it because they talk about a wellness economy or the health economy as an opportunity, not as a burden. So by marrying up the Ministry of Health with the Ministry of Economy, you can start to ask questions about where we spend our money and where are the opportunities for our country or for our region or for a city.
Andy, I mean, yeah, that's we can go on discussing, I think, a long road with the economics change and wisdom that you have just shared. Very simple but very complex at the same time, but very simple. I must say, it's already that time. Thank you again, everyone, for being on board today and joining APTA, AGE-WELL, and Numana's conversation. Jenna, would you have a small word of wisdom to share and to close up this beautiful conversation? Again, thank you, everyone, and we will stay connected.
Yes, thank you. You can see the clouds are passing in the window in front of me, so my apologies. But this conversation has been just pivotal for APTA in terms of the connections that we've formed here and strengthened here as well in this conversation today. And I think the themes that have come out of it is there's such an importance for aging in place in terms of our ability to leverage resources, whatever those resources look like, resources in the community, resources in hospital that can come in home into someone's home, family resources, your own personal resources, which includes your own health. So I think that this conversation has really inspired me and inspired APTA, and I hope it's inspired all of you. And thank you so much for your attendance. And thank you so much to our 5 panelists and Pascal for the moderation and co-hosting. It's been a pleasure.
Thank you.
Thank you.
Thank you.
Thank you.
Great
Bye-bye.
day. We'll connect soon. Bye-bye.
Merci.